So hello everyone, welcome to my channel. My regards and greetings to everyone who is watching my video and my lectures. So today I have brought a very special and important topic for you all, and the topic is a very important topic, that is hernia. And I'm not going to discuss a lot of things in the details of this. So I would just summarize it, because what I feel that laparoscopic hernia and its anatomy is very tough for all. So today I will be discussing what is triangle of doom, what is triangle of pain, and lot more important things about that. So let us join this journey of hernia. So let's talk about hernia. So when we talk about hernia, it's basically a protrusion of a viscous or a part of viscous via defect in a cavity. This is what is very simple thing. But I would like to discuss the anatomy of, you can say, groin. So the first thing is, today we are going to discuss something about inguinal hernia, or we would be discussing the groin hernia. To understand that thing, you have to understand the anatomy of groin. And for that, I have brought a very special, you can say, diagram for you, that is parasagittal view of the groin. And this parasagittal view of groin is very important. So whenever we talk about hernia, the first thing that you have to understand is the anatomy. Now when we transit from abdominal wall to the groin, you have to understand that there are three important muscle layers of the abdominal wall. What are they? From outermost, you have external oblique, then you have internal oblique, then you have transversus abdominis. So when this abdominal wall ends and the groin starts, how these muscles transform into a canal, let us try to understand. So the first muscle that I will draw in front of you, this is the external oblique. So if you see a parasagittal view, we have a view which is showing you the external oblique muscle. The second muscle that you have is the internal oblique. This is again very important. So this is the internal oblique. So we have external oblique, we have internal oblique. The third muscle that we have is the transversus abdominis. So this is the transversus abdominis muscle. So you can see that there are three important muscles: external oblique, internal oblique, and transversus abdominis. Now when the groin is ending, or when the abdominal wall is ending and the groin is starting, what is the fate of these muscles? Try to understand. The external oblique, which is on the outermost side will slide down in form of a curtain to form the anterior wall of the inguinal canal. So this is what is the anterior wall of inguinal canal, and this is what is known as external oblique aponeurosis. External oblique aponeurosis. And now this is hanging like a curtain. Similarly, this middle wall, that is internal oblique, this is going to form the roof of the canal. So this is the middle one, this is form the roof. Try to understand, to some extent, in the medial part, the conjoint tendon is formed. Now what is this conjoint tendon? It is nothing but the fusion of the internal oblique with the transversus abdominis. So transversus abdominis is fusing with the internal oblique to form conjoint tendon. So I would like to summarize it in a form that medial wall of the, you can say, the roof of the inguinal canal. Who is forming the roof of the inguinal canal? It is the internal oblique, and along with this internal oblique, to some extent, the conjoint tendon. So medial part of this roof is formed by the conjoint tendon. And what is the conjoint tendon? It is nothing but the fusion fibers between the internal oblique and the transversus abdominis. Similarly, as you go posteriorly, the transversus abdominis will again hang like a roof, hang like a curtain, and form the posterior wall. So who is forming the posterior wall, students? It is formed to some extent by a muscle which is known as transversus abdominis. Now the game starts. There is one more layer behind, that's a peritoneum-like layer, not peritoneum. And what is that? That is fascia transversalis, and this is what is very important. So do you know that fascia transversalis is forming the fourth layer, and it has two layers? So this is what is very interesting thing, that there are two layers of fascia transversalis. So fascia transversalis is having the anterior layer and the posterior layer, and after this it's peritoneum. So you have to understand that the floor is a very composite structure. But before understanding floor, you have to have a complete idea about what is the anterior wall and what is the posterior wall. So anterior wall is by external oblique and posterior wall is by transversus abdominis and fascia transversalis, and this is what is very important. Now just see one thing. Anteriorly, the external oblique is hanging like this and it will roll on itself to form a ligamentous structure which is known as inguinal ligament. So this is nothing. So the inguinal ligament is nothing but a condensation of what? It is the external oblique aponeurosis. Try to understand, the external oblique which was hanging like this has rolled on itself. Similarly, the posterior wall which was formed by transversus abdominis and fascia transversalis, they will also condense on it themselves to form a similar ligamentous structure, and this is what is known as iliopubic tract. So my today's lecture is based on the concept of iliopubic tract. Students, if you don't understand iliopubic tract, you don't understand anything about the laparoscopic anatomy. So I will like to share one important piece, that floor. If you talk about the floor, who is making the floor? In majority of the cases, the major component of the floor is by the inguinal ligament, but the posterior most portion of the floor, it is also made by iliopubic tract. And if you don't understand this, you will be always confused with the laparoscopic anatomy. So tell me one important thing, that what is forming the floor? Yes, major section of the floor is formed by the inguinal ligament, but the posterior component of the floor is formed by the iliopubic tract. The next very important thing that you have to understand is iliopubic tract is forming the base of the deep ring, and this is what is again very important. So what is a deep ring? There is something which is known as superficial ring, there is something which is known as deep ring. Now deep ring is a defect in the fascia transversalis. Superficial ring is actually on the external oblique side. So superficial and deep ring, and this transition between them is known as inguinal canal. Now if you talk about the contents, we have to be very judicial in this. What is the content of the inguinal canal? It is the spermatic cord. But if you try to understand who forms the spermatic cord, answer is the gonadal vessels and the spermatic, that is the vas deferens in majority of the cases. This is the major component. So who enters the canal from the medial side? Answer is, it is the vas which enters the canal from the medial side, and this is how the things are. This is how the things are. So this is the vas. Who enters the canal from the lateral side? Answer is, the gonadal vessels enter the canal from the lateral side, and together they make what, students? Spermatic cord. So the gonadal vessels enter the canal. They enter the canal from the lateral side, and vas enters the canal from the medial side. And if you have an idea to this, you will always understand each and everything. Remember students, this diagram is very important. If you don't understand this diagram, you will never be able to understand anything. What is the crux from this diagram? When we talk about the orientation, this is what is very important. What is that? Let us see. The orientation of hernia repair. Now because if you don't have orientation of hernia repair, you will keep on struggling with what is the triangle of doom, what is the triangle of pain. What is the management of any hernia? The management of any hernia is reduce the hernia and do something to prevent its recurrence, and that is why we put meshes. So try to understand. I'm showing you a box diagram. So let me represent the inguinal canal by this box. So this is inguinal canal, as we all can cherish that this is looking something like inguinal canal in form of a box. So if I'm talking about inguinal canal, so this wall should be representing the posterior wall, and thus this posterior wall is actually nothing but the fascia transversalis. This is what is very important. The next thing is, this is the anterior wall, and if you talk about the anterior wall, what is anterior wall? This is the external oblique. If we develop this orientation, you will never get confused. Now the second box, from where the content is coming, the abdominal cavity. So let us make the content cavity also. So this is the abdominal cavity from which the content is protruding into the, you can say, inguinal canal. So it's very important for us to understand that yes, the content is coming from the abdominal cavity. So this is abdominal cavity. So I hope you can understand that who will be forming this wall of inguinal canal. This is what is peritoneum. So if you see, we have seen peritoneum, which is forming the lining of the abdominal cavity. Then we have the fascia transversalis, and then we enter into the inguinal canal. So if I want to reduce the hernia and prevent its recurrence, I will have to place the mesh. So the next task is, where do we place the mesh? So mesh placement is big headache. So where is the mesh placed? Answer is, sir, it is placed in an avascular space. The answer is very simple. It is placed in avascular space. So what is that space? In the open hernia, repairs, we always enter the canal from the anterior side and the mesh is placed into the canal. So if we talk about the mesh in this case will be placed inside the canal. So in the open hernia repairs, the mesh is placed inside the canal, and this is a universal truth. So mesh is placed, it is placed inside the canal. When we talk about inside the canal, that means in between the anterior wall and posterior wall, we place the mesh. This is how the things are done. But when we talk about laparoscopic repair, we never enter the canal, and that is what is the crux of understanding anything. So if you talk about the laparoscopic repair, where do we place the mesh? The answer is, the mesh is placed in the space between the peritoneum and the fascia transversalis. And if you understand this, you understand everything. That in laparoscopic repair, whatever repairs are we doing, whatever anatomy we are manipulating in between the peritoneum and the fascia transversalis, and that is the place where you will find triangle of doom also, triangle of pain also. So mesh placement in case of laparoscopic repair is behind the canal. And when you talk about behind the canal, what do you understand? That means in between peritoneum and the fascia transversalis. Do you know what is the name for this space? This space is known as pre-peritoneal space of Bogros. So if I show you this space, this is the space which is known as pre-peritoneal space of Bogros. And why is this space preferred? Because this is completely avascular space. So this space is known as space of Bogros. Now let us talk about the space of Bogros and the important triangles. So important triangles of laparoscopic repair. So when you're talking about important triangles, why you tend to get confused? Because you tend to mug up the things. Remember, surgery is an emotion, and emotion can never be mugged up. You have to feel it to cherish or enjoy it. So try to understand that whatever repair we are doing in laparoscopic surgery in context with hernia, we are doing it in the pre-peritoneal space, where behind me is the peritoneum, in front of me is the fascia transversalis, and I am sitting in what? Space of Bogros. You have to understand this. Now try to see, there are two triangles, triangle of doom, and there is something which is known as triangle of pain. So triangle of doom and triangle of pain. What are the two important things that we need to understand in context with triangle of doom and triangle of pain? Forget everything, just try to feel the things. So I hope you can understand that this is a deep ring. Okay, before that, so this is fascia transversalis, and this is a defect in this fascia transversalis which is known as deep ring. I hope you know that base of the deep ring is made by iliopubic tract. So it is the iliopubic tract which is making the base. Now who is entering the canal from the medial side? Answer is, vas is entering the canal from the medial side. Who is entering the canal from the lateral side? Answer is, these are the spermatic vessels which enter the canal. So try to understand, the spermatic vessels or gonadal vessels enter from the lateral side, and medially it is the vas. Now you all know that if in front is fascia transversalis, who will be behind? The answer is very simple. It will be peritoneum. So peritoneum is forming the boundary which is the base of this triangle. So can you understand why? Behind is peritoneum, in front is fascia. And there is a triangle here which is known as triangle of doom. Can you see? And who is bounding the boundaries? Medially it is the vas, laterally it is the spermatic vessels. Again, you again have to understand this is iliopubic tract. So there is iliopubic tract on one side, then there is spermatic vessel on the, or gonadal vessels on one side, and again in front is fascia, and front is fascia transversalis, behind will be what, students? Peritoneum. So you can jolly well see two triangles here. There is one triangle, this is one triangle which is known as triangle of pain, and there is one more triangle which is known as triangle of doom. So triangle of doom, triangle of pain, these are two important triangles, and together they form a trapezoid. Still, those who couldn't understand, one more way to understand it, let us see once again. This is the deep, let us make, this is the deep ring. I'll make a deep ring. Okay, this is a deep ring I have made for you. Now who is forming the base of the deep ring? Who is forming the base of the deep ring? It is iliopubic tract which is forming the base. Now who is entering the deep ring from the medial side? Answer is, it is the vas which is entering the deep ring from the medial side. Who is entering the deep ring from the lateral side? Answer is, the gonadal vessels are entering the deep ring from the lateral side. You know, in front is fascia. So in front is fascia. Who will be behind, students? Answer is, it is the peritoneum which is going to be behind. So together this is triangle of doom, where medially vas, laterally gonadal vessels, and this is going to be triangle of pain. Again, this together is known as trapezoid of disaster. Together they are known as trapezoid of disaster. So when we talk about the concept of trapezoid of disaster, why it is known as a trapezoid of disaster? Answer is, the manipulation in this space should be minimum or should not be done. The medial part of this, is known as triangle of doom. Now why it is known as triangle of doom? It's very important, because the content of this triangle is very important to understand. It is the external iliac vessel. So it is the iliac vessels which is the content of this triangle, and any manipulation done in this can damage it. And if you damage iliac vessels, in laparoscopic anatomy, in laparoscopic surgery, the biggest, you can say, trouble is controlling the hemostasis. And this is iliac. You'll have 1 minute, within 1 minute the complete, or if not 1 minute also, 30 seconds, the complete abdominal cavity is full of blood. Your camera is not showing you anything and the patient dies. If the patient dies, a triangle of doom for both the consultant as well as the, you can say, patient. So iliac vessel, then you have the genital branch of genitofemoral nerve, and you also have plus minus the femoral nerve as a content of this. The important thing is no dissection done in this triangle. No dissection to be done here. This is what is very important. The next, if you talk about, is laterally. If you talk about laterally, who is lateral present? What is the structure which is lateral? Answer is triangle of pain. So why it is known as triangle of pain? Try to understand the content of this triangle. The most important content of this triangle is femoral nerve. Then we have lateral cutaneous femoral nerve, LCFN. Then we also have the femoral branch of genitofemoral nerve. Now, why this triangle is important now? You have to understand that this is the iliopubic tract. These are the gonadal vessels, and I hope you can understand that this is vas. So as per the knowledge of this that we have discussed, this is triangle of doom, this is triangle of doom, and this is the triangle of pain. Now let us see the more or the bigger window of this. So this is how the hernia looks like. And when you are placing a mesh, so suppose I am putting a mesh. So let me create a mesh and put it for you. So this is a mesh that has been put. In order to secure the mesh in its place, we'll have to put the tackers. So when you are putting the tackers, or the sutures. If you tend to go below the iliopubic tract, you are going to suture the nerves. And remember, if the nerves are sutured, or you push a pin on a, you can say, nerve, what will happen? You will have a constant sensation of pain. So this is what is very, 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 very important. No sutures, no sutures. This is important. No sutures or tackers should be placed here. Why it should not be placed? Answer is there is increased risk of nerve entrapment. And students, if there is nerve entrapment, what will happen? This will lead to something which is known as classically CPPS. What is CPPS? Chronic pelvic pain syndrome. And then the patient will keep on requesting to you, sir, please, sir, the pain is there, the pain is there, I'm not able to understand why the pain is not going. So even you are not doing, because your eyes will not see anything which your brain doesn't know. So laparoscopic hernia surgery is not a surgery for amateurs. Yes, you should have a basic orientation of dissection. So I will show you these